Well, good afternoon, everyone. And for those of you not from IDRC, welcome to IDRC. The International Development Research Center does hold these kinds of public events as often as we possibly can when we have partners that we work with or colleagues of ours in the various areas of research that we support who we can coerce or persuade or encourage to come and talk to Canada at large, to a community of interested people, about the work that IDRC actually is doing on the ground across the various areas of research that we do support. IDRC is a novel kind of an institution simply because of our unique niche as supporting research for development across all domains of inquiry. In fact, in some ways, we look like a university where we have faculties, if you will, but programs, as we call them here, in agriculture and the environment, science and technology, social and economic policy, and the area that I'm responsible for, global health policy. And my name is Michael Clark, and I direct that program. And I'm very, very delighted that we have been able to coerce or persuade or encourage or positively influence Dr. Richard Gakuba to speak to us today. Richard has been instrumental in the launch and implementation of a national strategy on eHealth in Rwanda. And IDRC has been lucky enough to be able to work with Richard over several years now in supporting several areas of Richard's work, and building capacity around the use of information and communications technologies to support a national health strategy writ large for the country, and other areas in terms of looking at the issues around training and what kinds of infrastructure are best suited for a national eHealth strategy, including the use of electronic medical records. I'm not going to take any thunder from Richard because he's his own thundering spokesperson, so I want to give most of the time to him, but I do want to welcome you here. I also want to welcome very much the High Commissioner for Rwanda, who is here amongst us, and as the High Commissioner said to us just a while ago, IDRC is becoming her second home, and we're just delighted that that is the case. So very much welcome, Your Excellency, again to IDRC. So let me tell you a little bit about Richard and then let him speak to you. Richard is the director of the eHealth initiative in the Ministry of Health in Rwanda, and he's been in this position for a little over 5 years. He is a physician. He graduated with his medical degree from the National University of Rwanda in Butare, which I know pretty well. And he also has a master's in eHealth from Brunel University in the UK. Richard is responsible for, as I said, spearheading the development of eHealth in Rwanda, and he has led the process of developing a 5-year national eHealth strategy for the Ministry of Health. And he is now leading its implementation. Once one gets over the problem with developing a plan is that you're held to implement it, isn't it? And that's what Richard is involved in now in terms of implementing such a plan in collaboration with a number of development partners, government stakeholders, and I'm pleased that IDRC is amongst them. The eHealth strategy in Rwanda involves deployment of various technologies in the health sector, from the central areas of Kigali, the capital of the city, to the remotest areas of the country. At the current time, Richard somehow is able to divide his life into so many parts. It's a wonder to behold because he is, in addition to his responsibilities in Rwanda, he's also pursuing a PhD degree at the National University of Rwanda that is focusing on the impact of eHealth on strengthening of health systems. So, Richard, I'm delighted that you were able to join us, and I'm turning the podium over to you. Richard will be speaking for roughly 40-45 minutes or so. We'll leave it up to him to decide how long he wants to speak, because I do want to have a really good question and answer period following Richard's talk. I do know, as I mentioned to Richard, that eHealth is a topic on many people's minds in Ontario. And I think we could probably learn a lot from Richard, so I've asked him to bear this in mind as we go forward. I'm unfortunately going to have to leave because I have a plane to catch. Just as the Q&A session starts, I will stay for the opening of that session, and then I'll hand it over to my colleague, Dr. Sharmila Matre, who I'll introduce to you at that time. So, Richard, over to you, and again, welcome to IDRC.
Thanks, Michael. Your Excellency, the High Commissioner for Rwanda, dear colleagues from IDRC and other institutions, I think some of you, most of you actually from here in Canada, but I'm told there are other people who are online, so to everyone who is listening to this talk, I would like to thank the IDRC so much for inviting me. It's an honor for me to be here to share what we are doing in Rwanda, but also put it in the perspective of the rest of the developing world where we come from. And also to learn from, I'm sure during the Q&A I will also be able to learn from whoever will be asking questions or making comments. So it's an opportunity for me to be here to share what we are doing and to learn from each other. eHealth as a topic is quite broad, and just to make sure that we are all on the same page, it involves the use of technology in the health sector. So that's very broad. It's not just electronic medical records or reporting systems or e-learning. It's quite a lot, from logistics management systems to blood bank management systems, facility management systems, to reporting systems, and so on and so forth, and infrastructure, actually, to put it, and governance, in fact. So this is a very broad topic, and we've decided to choose one area, which is maternal child health, and how technology can be used to improve this area, partly because of the linkage of Canada to support maternal child health specifically through the commitment to improve maternal child health, as evidenced by the commitment of the Canada Prime Minister in 2010. So I know that it's a very important topic for you at national level, but also partly because maternal child health is one of the key areas for Millennium Development Goals for developing countries. So I'll try to focus my talk in that area, but please feel free to ask any question related to any other part of the health sector. Knowing that the audience, whoever is listening, are coming from different areas, I was short of choices of what to concentrate on, either be a lot more medical or be a lot more IT, so I decided to be somewhere in the middle, but also try to use some figures and numbers to demonstrate the importance of what we can use potentially, technology that we can use to improve the health sector. Let me start with just a few figures here. I'll use some figures from Rwanda, but also some figures from the rest of the developing world for you to understand the context. Maternal mortality, which is the number of live births out of 100,000. Number of deaths out of 100,000 live births. In the year 2000 in Rwanda, we had 1,071 deaths per 100 births. So that's a very, very high level compared to where we want to be. In 2005, it was 750. So some of you are doing quick math. You can see the decrease by then. And in 2010, which is last year, it was 487. So over a period of 10 years, maternal mortality has been halved, by 50%. It has improved by 50%. So that is really a very strong improvement. But please note those improvement percentages, because I'm going to make some reference to them later on. Generally in Africa, we have, in 1990, there was 780, the maternal mortality was around 780 deaths per 100,000 births. And in 2008, this has reduced to an average of 590. And This registers an improvement of about 24% over a period of 18 years. So this is 24% over a period of 18 years. But remember, I just mentioned about 50%, actually more than 50% over a period of 10 years. So that makes Rwanda become one of those countries that is improving very fast, and it is in line with attainment of the Millennium Development Goals. But again, as I'm going to make reference to this when we start talking about the technology, this is still not good enough. I've chosen two key areas, which is maternal mortality and under 5 mortality. And just to tell you a few figures about under 5 mortality, in 2005, we had 152 deaths. This is measured over 1,000 births, live births. So we had, in 2005, 152. And in 2007 to 8, we had 100. So that's 103, actually, to be precise. So that is, again, an improvement of about 30%. And in 2010, we had 76 deaths over 100 births. And that represents an entire improvement of 50% over a period of 5 years. So this data I'm using is from the Rwanda Demographic Health Survey, which is available. And again, to compare with the rest of the developing world, or actually to be specific to Africa, first of all, we know that the annual global deaths of children under 5 years of age fell to 8.1 million in 2009 from 12.4 million in 1990. This represents a 35% reduction, but over 20 years. So again, you can see that the trend globally is still very slow, although Rwanda registers a much more modest improvement, if I could say, which is 50% over 5 years, as opposed to 35% over 20 years. Again, like I will mention later on, this is not a desirable outcome to have. So, if we compare to developed countries, which today are our threshold, because we don't have anything better to compare with. If you compare all the developed countries, or the ones that are really highly developed, most of them below 10 deaths per 1,000 births. So much as we have improved to 76, we are still very, very far away to what our target is as a threshold. Like I said, sorry, I was our benchmark. So as you can see, there's quite a lot that we have to do to improve maternal deaths and child deaths and other indicators. So there are some interventions that have been done, especially practically in Rwanda and in other countries, to improve these figures. And some of these include, for mothers, for some of you who know about public health, the main cause of death is for mothers to deliver at their homes or without assistance from someone who is qualified or who has the right equipment and skills to deliver. So the main interventions are geared towards having these mothers go to deliver at healthcare facilities. But of course, before you do that, you have to have the healthcare facilities. And then you have to have good services in the healthcare facilities. And then the mothers should be able to afford those services. So there's a whole bunch of activities that are around, or programs that are around having mothers deliver at healthcare facilities in order to improve maternal deaths. So one of those includes like emergency obstetric care, which is available in all district and health centers. That is for Rwanda specifically. And we are still happy to have most of the people, the largest number of population, have a reasonable accessibility to healthcare facilities in terms of geographical accessibility. We reach the norm, the WHO norms, but again, of course, there is some improvement that's required there. And then we also have birth kits, which are put in all these healthcare facilities. We also have improved a lot in emergency transport, where every district has ambulances, Actually, some health centers also have ambulances, depending on the kind of support that they have. So there has been very significant improvement in having the healthcare facilities, first of all, having the right equipment in the healthcare facilities, and having emergency transport available to transport mothers, because it's always an emergency when it comes to giving birth. Then on the information side, we also have maternal and neonatal and child death audits. I was hesitating to talk about technology yet, but let me mention something that every Friday we have data that is put into a system to record every maternal death that took place within that week, so that if anybody at a program level or ministry level can log in and see how many deaths actually took place in every district. And then by the end of the month, all the audits are done. The health centers have people that go down to the community, they do the death audits, and the whole file is brought to the central level. Still paper-based, but the reporting of numbers of deaths is reported electronically. But then, of course, the audits they have to be done right at the point of where someone died. So I had to mention that while going forward. The other information intervention is that we have verbal autopsies for maternal, neonatal, and child deaths in communities. So that also helps us to know the profile of maternal child health care at a community and district level. Then from a human resource level, we have deployed midwives in all healthcare facilities. Again, it's a big challenge because in the past we did not have midwives schools in Rwanda, but now we're training midwives, and as soon as we train them, they go down to the communities to start serving. The other intervention is health financing, which is the main part that I will talk about here. Is first of all the health insurance. So we have community-based health insurance, whereby it's a policy, actually it's a law in Rwanda, that everybody should be insured for health. So we have the community health insurance where up to more than 80% of the population is insured. But of course there are other insurances like the civil servants health insurance and other private sector insurances. So all in all, we are close to attaining that 100% of full insurance health coverage. And that is obviously helping these mothers, especially the community health insurance is helping these mothers to afford healthcare facilities. You all know the two different models of healthcare financing, which is you either provide healthcare for free, and then basically the government will invest in paying the doctors and nurses and buying the medicines and the equipment, and then you're probably going to pay a lot of tax for the government to be able to do that, as opposed to let the people afford the insurance and actually pay for the services. So those are two different models that you wouldn't. There's no model that fits best all countries. I'm sure every country will have its own best model, but it has worked so well for us to say, let the people be able to afford the services instead of making the services free, because there's all lots of advantages attached to that. So mothers, when they are pregnant, when they are going to give birth, they don't have to worry about paying the bill. Or if a child is sick, someone doesn't have to worry about having money out of pocket to go and pay, because they are already covered by the health insurance. And maybe let me talk a little bit more about that, because it's a very, very important program that we have, whereby we have about 25% of the entire population belongs to a certain category where they can't pay for themselves the health insurance. So the government has to subsidize and pay for those. But then the rest, we have three categories. So we have the first category who can't pay for themselves, which are about 25%, actually to be precise, 24.6%. And then we have two other categories who pay different amounts depending on their socioeconomic class. And we have categorized the entire population into those socioeconomic categories. We have a database which where everybody belongs to a certain socioeconomic category, and this is carried out at a community level. It's not us, the national level, who say, okay, you belong to this category. No, it's the people themselves at a village level who sit and decide who belongs to which category. So we have an electronic database of those, and depending on which category you belong in, you pay a certain amount of money. So in terms of healthcare financing, that has been very helpful. And the other thing is that we also have performance-based financing. So nobody's salary is guaranteed 100%. You have to work for it. So this goes down up to the community health level. Maybe let me just talk about the community health level. We have community health workers, 4 per village, and each village has about 50 to 100 households. And these community health workers are actually volunteers, but they are elected by the community themselves. But in every intervention that they carry out, they are reimbursed for what they do financially, so that it's not a monthly salary that they expect, but it's a pay-per performance. So the number of mothers that you transfer for healthcare delivery at healthcare facility level is equivalent to a certain amount of money. So, and that money is given to the community health workers through their cooperatives, and they use the money for either for individual purposes or for the cooperative developmental work. So that's another healthcare financing model that has helped to improve maternal-child health. There are other interventions. I just wanted to mention a few that are really directly linked to maternal-child health. We have mosquito-treated bed nets. That has been very, very important in reducing malaria. We have the early treatment of malaria as well at a community level. Excuse me. The community health workers also prescribe and dispense anti-malarials, and also distribute mosquito nets, of course. So we have had a very, very, very large success in terms of reducing malaria because of those two main interventions. And that has contributed a lot to reduction of under 5 mortalities. And of course, there are other programs like family planning and nutritional programs and so on and so forth. Now, having talked about healthcare and healthcare outcomes and the different trends, let me just switch a little bit and talk about the technology trends that we have in this world. Again, I'll mention some figures here. We have, in 2010, more than 2.6 billion people worldwide lacked access to toilets or other forms of improved sanitation. So talking about 2010. But 4 billion mobile cellular subscriptions there was 4 billion mobile cellular subscriptions in the developing world. So if you compare those two, I mean, you have almost a half of the population do not have, access to certain healthcare basics, but they do have mobile phones. So if you put that into context, you see like we are missing a point somewhere in terms of improving healthcare. The other point is that mobile cellular penetration in the developing world reached 70% at the end of 2010, just 6 years after reaching 70% in the developed world. So it took 7 years for the developing world to catch up with the developed world. Not to catch up, but to be where they were 7 years earlier. But if you remember the figures that I told you about the improvement of healthcare outcomes, the difference is so enormous. So we are nowhere close to being where Canada is in terms of healthcare outcomes, but we are very close to where they are in terms of mobile phone coverage, for example. So again, when you think about that and how quickly it has taken for us to reach there, you realize that something has to be done. Other figures, and this is ITU data that I'm quoting, in 2002, just 2 countries in the world had mobile cellular penetration over 100%. 8 years later, almost 100% economies had mobile cellular penetration over 100%. When you make such a comparison, you're like, wow, technology is improving so fast at a really very high level. And again, in reference to the data that I just mentioned, 17 economies had penetration rates above 150%. So we are talking about between 2002 and 2010. So you have, first of all, you have 2 countries that have up to 100%. Then you have almost every country reaching 100%, and you have 17 countries at 150%. So that is also a very, very strong improvement in the way technology is improving. That was about mobile penetration. Global internet user penetration reached 30% in 2010, and in developed world countries, this is global. It reached 30% in 2010, but in developed countries it reached 30% just 9 years earlier in 2001. Again, when you make these comparisons, you'll figure out something. Then in the year 2000, internet user penetration was under 1% in 72 economies. 10 years later, there were just 6 economies with internet user penetration under 1. So again, these are figures that are really, these are figures that are really giving us a no-brainer. Say, okay, come on, if technology is improving like this, how can we piggyback on this and make sure that we use it for healthcare? Just maybe a few other figures. We have mobile cellular penetration in Africa in 2010 was 45.2%, okay? And was higher than mobile cellular penetration in Africa in 2010 was higher than in the Americas in 2004, okay? Basically, in the Americas, it was 42.8%, okay, in 2004, and then in Africa, it was 45.2% in 2010. So 6 years later, we are at where the Americans were in terms of mobile cellular penetration. And then, continuing the same figures, mobile cellular penetration in the Americas had grown to 94.5% by 2010. So you can see how fast, even in the developed world, these figures are really changing very, very, very fast. In Asia and the Pacific in 2010, mobile cellular penetration was higher than in Europe 8 years earlier. Okay? In Asia, we had 69.2%, okay? But 8 years earlier, in Europe, it was 67%. So that shows you how, if you compared Asia and Europe, how quickly the Asia caught up with mobile cellular penetration. But again, when you look at the data related to healthcare, you realize that the trend is definitely not the same. Talking about internet, we had internet user penetration in Africa grow over 20-fold in the decade to 2010, from 0.5% to 10.8%. If you recall the figure that I talked about, let me just go back a little bit. We had in Africa maternal mortality rate in 1990, and in 2008 increased by 24% over 18 years. But now we are talking about how many fold? A 20-fold over a decade. So, I mean, these are comparisons that are really appealing to us to say, let's do something about it. We also had internet user penetration in Asia and the Pacific grow from 3.3% in 2000 to 22.5% in 2010, bringing it closer to the internet user penetration in Europe 9 years earlier. Okay, it may be enough about figures on mobile phones and internet. But again, coming to the price now of all these technologies, you all know how much a cellular phone costed, let's say, 10 years ago. A very smart phone. At that time, obviously, they weren't very smart, but again, they were very, very expensive. But how much does it cost now to buy a smartphone that can do pretty much what a computer can do? You can see that the price trends are also almost the same way the technology is improving. The prices are also coming down. And this is not only to the developed world, but also to the developing world. You all know that the cost of bandwidth, I'm not sure what it was in Canada way at the beginning, let's say 20 years ago, but at least in the developed world, we know that the prices have say, for example, over about 6 months now in Rwanda because of our connection to the international fiber backbone, which is the undersea fiber backbone. The prices of internet have come from an amazing $2,300 per megabyte per month, which I'm sure I think here you have about $40 for 10 meg per month, right? While we used to have $2,300 for 1 meg per month. So if you make those figures, you see how amazing that was. But that has reduced now. It is possible to get 1 megabyte for 300. I mean, we are not yet where North America is in terms of the price for bandwidth, but that shows you the improvement. So what is very important in all these healthcare trends, healthcare and technology is not just the figures that we have today, but there's the rate at which we are improving this. The improvements are being made. Because if you take an example for healthcare, for example, where we have improvement of 55% for maternal mortality, by the year 2015, we are likely to be even half that improvement. So the trend is what matters most, other than looking at the figures that we have today. And these trends are really promising, be it on the healthcare side and on technology side. But obviously, the technology side is much, much faster, and the trends are much, much more amazing. So what can we do to use this technology to improve healthcare outcomes? In the next few minutes of my talk is what I'm going to concentrate on. And we know that technology is not the magic bullet. Let me just make this very clear. It's not that once you use technology, then things are going to change overnight. Obviously not. All those improvements that I mentioned in healthcare are definitely not due to necessarily having used technology. So one would argue out that if we've improved over time, why invest in technology? But I think, to me, I don't know what it is to everybody else, it's a no-brainer to say that if you use technology, you would obviously increase even that increment that you had. So, but it's very key to note that it's not technology alone that's going to improve this. It is very many other factors that I'll briefly mention about. So, knowing that technology is not a magic bullet, you have to invest in other things. And one of them, I'll give you examples. If you do not have a functioning community health workers program, there's no way you're going to implement a mobile application technology at a community level. Or maybe there could be some, you can be innovative and get technologies that the users, the clients or the patients themselves can actually use. It's true. But there are some areas, especially in the developing world, whereby some of those people do not have mobile phones. And it is easier to actually put the mobile phones in the hands of the community health workers who are closer to those people. So the technology which you implement is so reliant on the existing systems, right? And on the other hand, it is so reliant on governance. If you do not have an organized way of planning and implementing and executing and making prioritization and engaging all the stakeholders to make sure that you all implement these systems together, there's a very high chance you're not going to succeed. So it's not just that we have the technology and it's working, it's also all about the leadership and putting it in place and making it work. Just a small example of where I come from in Rwanda. We have, in the Ministry of Health, we have a whole department in charge of eHealth, which is, I think, the first of its kind. I'm trying to pat my back here. In the region, to have an eHealth department. It has always been traditionally an ICT department, which is mainly in charge of making sure that some computers are working. It's more of a help desk kind of department, and to make sure that internet is up and running, and mainly at a ministry central level. So it doesn't necessarily focus on improving healthcare outcomes. So that alone, to have a department that's dealing with these issues is a very, very strong point. But very key to that as well, we have an eHealth technical working group, which meets every Wednesday at 9 a.m. to plan and discuss and agree on all these different eHealth priorities, and we advise the ministry or the minister and all the others about what should be implemented, which technology, how to implement it, and so on and so forth. And this technical working group is composed of the Ministry of Health, the implementing partners, who I know the NGOs and funders of some of the programs, and other government stakeholders like the department in charge of ICT, the ministry in charge of ICT, and so on and so forth. So that multi-stakeholder technical working group actually makes my life easier, because I'm the one who is leading that group, because there's lots of experts from all these different entities that advise you, for free, if I would say, because they are free consultants, in other words. Yeah, so leadership is very key. While talking to some of you, I've realized there's a lot of interest in vital statistics and the way data is collected. So just also to mention that we have a technical working group that is harmonizing the way vital statistics is collected. Vital statistics has always been a function of local government because it has that legal attachment to it. Before you get your passport, you have to be registered, you have to bring your birth certificate, and so on and so forth. So there's that whole attachment of the legal part of it. So the law stipulates that you have to be registered by the local government. The birth and death registries are done by local government. So we realize that in the health sector, we have almost 100% of everyone who is born in one way or another within the first month of their life are in contact with the healthcare facility. Either they are born there, which is about 70% of them, or even if they are not born there, they came for immunization or they came for a certain ailment of some sort. So we know that, and of course vaccination is a very key one. We have about over 90% vaccination coverage. So when you put all those things together, in one way or another, someone who is born within the first month is going to be in touch with a healthcare facility. So it's a no-brainer to say that a vital registry, at least for births, should be collected at a healthcare facility, and that data can be fed into, without even changing the law, the data can be given to local government for aggregation and so on and so forth. So we've created this committee, which is formed of Minister of Health, Minister of Local Government, Minister of Justice, and Institute of Statistics. And we are harmonizing these forms and coming with one form which is going to be used both where we have an electronic system, but also where we don't have. It will be the same form, but in a paper format that is used at the different levels. So again, that's about leadership. It's not about, I think everybody knows that it's important to have one form, but having it done is one other thing. So I thought it was important to talk about a little bit about leadership there. Let me just mention a few eHealth applications. Again, I'm going to only focus on those that are related to maternal child health that we have in Rwanda. Like I mentioned earlier, we have, and actually it was also mentioned that we have an eHealth strategic document, which encompasses the entire healthcare system, as I should say, technologies that are targeting different healthcare areas. But I've just picked a few that are related to maternal child health. And these are either all of them, not all of them, sorry. Some of them are at the level of implementation, others are at the level of planning, and others are already implemented and fully functional. But the ones that I'm mentioning here, I'll also tell you the status. So first we have an e-learning program, which is a program that we are training. We haven't started, but we have put everything in place. The enrollment has started, and the nurses will be starting to study next year, hopefully in January, if there are no other delays. And this is a program where nurses who would otherwise not be able to go to the nursing school to upgrade are going to have an opportunity to study and upgrade themselves from what we call ordinary nurses to registered nurses level. So that e-learning program, actually, I have to mention here that the IDRC has been supportive of that, has supported the rollout of the implementation of this, buying the equipment, and the initial funding for for developing the program has always been funded by IDRC, and I should say thank you for that. And this program is quite vital. As I said earlier, one of the solutions, interventions that we have is to build human resources, and this is the one way of using technology to build human resources, teaching all these midwives to be able to improve maternal child health. The other one is we have two-in-one, I would say, systems. One is called Rapid SMS, which was a system developed by UNICEF, but we have adopted and changed and kind of customized for Rwanda, is one where it's fully functional now in one district, but we have trained trainers in all the other districts, and because we have provinces. We have 5 provinces, and we have trained all the community health workers now as I speak. I think we have one more province to go, but the system is fully functional in one district. Now, this is a system whereby when a mother is pregnant, the community health worker will go and register that mother. First of all, every mother has a national ID, so they have a unique identifier. So they register the pregnancy, and if there is any event that takes place in an event like bleeding or fever or anything, that is also recorded. An SMS is sent, and the system will build a medical record for that pregnant mother. And also when the mother gives birth, the outcome of the delivery is also recorded. So is it a live birth? Is it was there any other complications? Those are also recorded. And the child is also followed for 45 days afterwards. And there are some indicators that are recorded. And that helps us to track the life of a mother throughout their pregnancy. And that's very key, and also builds, obviously, a lot of data that we use for when you aggregate it. We also have, like I said, they're kind of two-in-one. One is called M-Ubuzima. M-Ubuzima means mobile health in Kinyarwanda. M standing for mobile, because there is no Kinyarwanda word for mobile, and Ubuzima means health. So M-Ubuzima is a connotation for M-Health, and this is a system which we use for collecting MDG-related indicators at a community level. So it's not only healthcare-related, by the way. So all the healthcare-related indicators are collected at a community level, but we are rolling out this at the same time. So it's not yet fully functional at national level, but it will be because the training is going on as I speak. The other one is electronic medical records. We have internally developed an open source, or we have actually customized an existing open source electronic medical record called OpenMRS, and we are rolling this out at healthcare facility levels, targeting primary healthcare. So the development, as you all know, software development is never complete. There's always improvement, but we have what I call version 0.1 that we're implementing right now in healthcare facilities. And again, here we have support from IDRC, and it's very much appreciated. We also have the online weekly maternal death reports that I mentioned, so I won't speak about those so much. We also have the shared health record, what actually is called the Enterprise Architecture Project. It's quite broad, but what it involves in very simple words is that when somebody goes for treatment in a healthcare facility, he receives the treatment, but if he or she goes to another healthcare facility, their previous records can be seen, so you can make reference to the previous records, and there's a continuation of care for that person. In simple terms, that's what it means. But in implementation terms, it means quite a lot of things. It means having unique identifiers for individuals, having unique identifiers for providers, for facilities, having terminologies agreed upon. How do you call malaria? Is it one standard way you call it, or do you have different ones? Terminology standards for drugs, and so on and so forth, and making all these things linked together. It sounds quite easy when you say it like that, but it's quite complicated. So, so we have that project, and again, we have some support from IDRC and other donors and other funders like the Rockefeller Foundation, the USAID, and others. And that is something that we hope is going to improve maternal child health. In fact, our main target area is maternal child health. To start with a continuous maternal health care record. So that's going to be our, if you want, the word pilot. So in conclusion, just wanted to draw your attention once again to the trends that are there in technology and healthcare, and try to see the obvious, I think obvious actually, trend that we should use technology to improve healthcare, and try to see if we can bring those to at least, even if it is 50% of the speed of technology, I think to be much more appreciated. And then the other thing is that we have to use existing technologies. We don't always have to reinvent the wheel, but where possible, innovations should be done, because there are many areas where there's a need for innovation a lot. I mean, today you can use your phone right now, buy an air ticket, jump onto a plane and go to Africa. It's so easy, but you can't very easily say, okay, can I even know what I'm suffering from, or can I even talk to my doctor right now? It may not be that easy. So in terms of innovation, a lot has been done in the other sectors, but in healthcare, I think there's quite a lot that is still lacking. Another thing is that we have to document best practices. It's very, very important, so that we can learn from each other and share all the things that one should not do while implementing e-health systems, but of course also to share what should be done. But for me, I think what should not be done is also actually much more important. On the other hand, we also have to evaluate what we have. It's important to prove that these things actually work. It's important to bring evidence and show, okay, look, these things are working, because this is going to be very helpful in leveraging resources, in making sure that those who have the check can understand and say, okay, here you go ahead and implement. So it's important to show some evidence, because it's very important in everything that we do, while, however, knowing that we shouldn't use evidence as a deterrent factor to implementation, because sometimes in some areas you realize that technology has been put under scrutiny, under a much more complicated magnifying glass than the rest of interventions. So it's very important that we do not focus only on evaluation and make it becoming a deterrent factor to implementation of technologies, because there's quite enough proof already, but some people really want to take that proof, the search for proof, so much far that it becomes sometimes a deterrent factor for implementation. I think that's all I had for you. I don't know how much time, maybe I've used all the time. Okay, thank you so much for listening.
Thank you very much, Richard, for a very revealing narrative and a description of how one country can actually get it done. I'm particularly impressed with the emphasis that you put on governance and leadership. I think that is absolutely critical, because I think many of the incidences and situations that have been faced around the world that have tried to implement such solutions maybe have not succeeded as well as you have because of issues around who is eventually accountable and who is responsible, and where does the visionary leadership come from in moving this forward. Interesting comment on the role of evidence as a deterrent for moving forward. Being a research organization, an organization that supports research, we, of course, like to think that evidence is forming at least one of the components for decision and policy making. But at the same time, I think the point has been made very clearly by Richard that innovation probably doesn't wait for evidence to be generated in many cases. And innovation is that undertaking of risk that perhaps will be proven downstream. And I think we have to understand that as a research organization ourselves. So I take what you've said quite seriously in terms of how this might apply to other situations around the world, and how we might be able to learn from Rwanda's leadership in this area. So thank you very much again. I would like to open it up for your questions and your comments, because there's a lot of issues that Richard has touched on. And I will say, I will make actually a very quick reference to the United Nations Commission on Accountability and Information for Women and Child's Health. And the reason why that's so fresh in our minds is because the UN Commission was actually here in Ottawa on Monday and Tuesday, and our colleagues from CETA and WHO were responsible for organizing 2 days of very intensive meetings, because now that the Commission, which as you know was co-chaired by Prime Minister Harper and President Kikwete from Tanzania, the Commission has done their job. They have published their report. They have kind of, what I heard when it was tabled was the sound of rubber hitting the road. And as a consequence of that, the last 2 days were intensively focused on how are we actually going to move forward on this to address those 2 MDGs that have seemed to be very, very elusive up to this point. And I must say there's political will there. This commission, when it came into town, was represented by the Tanzanian Minister of Health, by the Director General of the World Health Organization, by Bev Oda, our Minister of International Cooperation. So there is political will, and I heard and smelled more rubber hitting the road at this meeting, because they threw down the gauntlet to all of the interested and engaged stakeholders, including those in country. Richard will have heard and the same sound that I did, and we as organizations that try and support countries to reach the MDG targets, as difficult and challenging as that may be. But the political will is there, and now I think we've got to actually implement what it is that we've been challenged to do. So this is all very fresh in our minds. Richard's talk is very timely, and I would now open it up for your questions or comments, so please. Yes, please. Could you come up to the microphone and identify yourself, please?
Hello, thank you, Richard. It was a wonderful talk. My name is Kevin Dooley. I'm a member of the public. I'm just on your mailing list. I think it's very comforting information for the FYI and whatever. But on that note, can you give us other pictures? You're talking in general here, but I'm not getting a sense, and I'm just speaking for myself here, of the population, the size of Rwanda. I don't know this, like the size of Rwanda, the population, the mortality rate, some other figures, please. This stuff is very, very good, but it's lacking. I'm lacking something here. I'm not getting a full picture, and that would be in relation to the numbers in the population growth, the size of the population, the numbers of people you're looking at, and also the income level, the life expectancy level. Those figures, please. If you could give me a better profile on it. Thank you.
Thank you very much. Richard, what we'll do is we'll take 2 or 3 questions, comments, and pull them together. Yes, please.
Hello, my name is Isabelle Roy. I work for the Canadian International Development Agency. Thank you very much for your presentation. It is very refreshing to hear some examples from the ground, because we have a tendency sometimes to keep too much of a high-level view. So thank you for that. I am interested, getting back to the high-level view, I am interested in hearing, you talked about governance and leadership and multi-stakeholder approach, recognizing that the private sector plays an important role in the health care service delivery. I would like to have your views and hear about your experiences on how you were able, I'm assuming, to engage with the private sector, both from a health delivery perspective and also in the data collection, monitoring and evaluation. Thank you very much.
Merci. Merci beaucoup, Isabelle. At this point, I'm going to, unfortunately, have to leave to catch a plane. So I'm going to ask Dr. Sharmila Matre to come and complete the moderating of this, if that's all right. Dr. Matre is the program leader for our Governance for Equity in Health Systems program at IDRC. So once again, I personally want to thank you for coming. And Richard, I will see you in Kigali very soon. Thank you very much.
Let me make some reactions to the two to the questions that have been asked by the two participants. First, from, is it Kevin? You are interested in knowing the about Rwanda in general, and where do these figures come from? In terms of size, Rwanda is about 26,000 square kilometers. So it's a reasonably small country with one of the highest population in the population per square kilometer in Africa. Okay, so it's a very highly populated country, small in size, very mountainous. For your information, it's called a land of 1,000 hills. But those who have been there say it's very beautiful. It's the Switzerland of Africa, they say. Anyway, the life expectancy is 52 now, and for the first time in 2008, the life expectancy crossed the 50-year margin. So, again, that is one figure that I didn't talk about, but it's something that's showing a lot of improvement. In terms of economy, the GDP, I will use the GDP as an example. About 5 years ago, more than 5 years ago, maybe 6 or 7 years ago, was about $240, but now it is 540. So there's again has been a lot of economic improvement. It's one of the countries where the growth rate, economic growth rate, is estimated for 2012, estimated to be 70%. Whereas there's a lot of, because of the financial crisis, there's a lot of decline in economic growth in many countries. There has been steady growth over time. Again, maybe I can't remember the figures very well, but in the whole region, the inflation is the most stable currency within the region. Our currency is the most stable. So that is just to give you a context of other non-health, non-technology issues. So I hope I've answered your question. And the question from Isabel, how the private sector is playing a role in this. First of all, I have to mention as a background that healthcare delivery in Rwanda is, I think, I don't know the right figure, but definitely more than 90% is public. So most people, all the people who attend healthcare facilities, more than 90% are attending public healthcare facilities. So the private healthcare industry is still growing. Just like, by the way, it's not only healthcare. Even in other sectors, the private sector is still growing. In fact, sometimes the government has tried to incubate private organizations so as to start some health sectors, to put them on their feet and start running in terms of private sector. So the healthcare-wise as well, the private sector is still very small. We actually still have challenges in the two areas that you mentioned about. One was about in healthcare delivery. Like I said, there is a very small private sector industry in healthcare. But in data collection as well, there's investment that you have to do in implementing these technologies. And we have not reached a level where you have to oblige the private sector to have an electronic medical record, for example. So you can't tell them, yes, this is the standard that we have, you must have it. And at the same time, it becomes quite difficult to demand from them data for healthcare data collection. So when you say, I need this and this and this data on a regular basis, again, it becomes a challenge. But we are trying to involve them as much as we can. But in terms of planning and implementing eHealth in general, those private sector companies that have a role to play in some areas, we do invite them most of the times, depending on the subject of discussion, to our eHealth meetings, so that they can make contributions, and also to the strategic planning meetings. They are all invited. Just to mention two examples, we have one of the telecom providers who has given us kind of, you would call it social corporate responsibility, whereby all the reporting that is done using mobile phones, the service is free, so we don't pay for those calls. But of course, they know that the private sector, it's basically not free for that. But for that matter, they are trying to improve the health of the people that are actually their clients. But on the other hand, we also we have partnered with one of the telecoms once again in providing services for community health workers reporting. The one that I mentioned that is free is for HIV reporting, which is in 200 healthcare facilities in the country, over 200, which is actually 100% of all healthcare facilities offer HIV services. They report using mobile phones, and that service is free to call. But we do have the community health workers reporting system that I mentioned during my talk, whereby we've come to an agreement where we pay a small fraction of what they charge other services. So there's a partnership there that we have established. And on the other hand, we have the intention of the ministry to implement this eHealth strategy is not to develop systems internally all through, or to create a very big IT team in the ministry, but to partner with the private sector, with private companies that can actually develop the systems and support them. So in one way or another, we are creating jobs for them and giving them business as well. So that's how I could talk about the private sector engagement.
Hello, Richard. How are you?
Fine, thank you.
We are really quite democratic at IDRC, so in 15 minutes there's going to be a new chair. No, just kidding. So before we go to other questions, Kevin, I gather there's something called a confidence monitor?
So I haven't got any questions yet.
Okay. So we're trying to also run this to have access. Would you like to go, Anna?
Thank you for your presentation. My name is Anna Seyfried, and I work at the Global Health Research Initiative. You had mentioned the importance of evaluation in your presentation, and particularly sharing what should not be done. I was wondering if you could expand a little bit on that and tell us how you will evaluate the eHealth program in Rwanda, and who will carry out the evaluation, what strategies will be used, and if there are any results so far that you can share with us on what has worked and what has not worked. Thank you.
Let me just take one. Would you take a few questions?
Okay. Hello. My name is Helen Johansson. I'm an adjunct professor at Ottawa U, but for most of my career, I did record linkage at Statistics Canada. And first of all, I'd like to congratulate you on very impressive results and the amount of activity that's gone on with eHealth. I'd like to look down the road at the usefulness of these records and just say that they're also useful for looking at things on a community or on a particular disease or a particular procedure basis. For example, if you look at all the people that have a heart disease, and then look at how many had a revascularization, say, within a month, and then how many survived, whether they had a revascularization or not. In other words, looking at health outcomes, looking at evaluation of certain policies, and certain ways of doing things. And I think that's very important. And as we talked at the before your presentation, at building this into the system right from the very beginning. And I was very impressed that you've talked about standardization of records, because this is one of the things that's really needed to make sure that these records, and they are very, very important for their primary use, which is to improve the health of the individual person, but they can also be used then to improve the health of the country and the health of the healthcare system by making the data available for more broader analysis. Thank you.
Hi, I'm Eva Rathgaber. I'm a consultant in international development. You spoke a bit about the kinds of applications that are available for healthcare workers right from the community level up to the ministry, which was interesting. Turning it around, you said, and I know I've seen it myself, that cell phones are commonly available to everyone now, almost everyone. To what extent are applications coming on the market in Rwanda that are helping people to look after their own health? And could you also give some attention to women when you talk about that? Thanks.
Thank you. You'll forgive me if I don't get your name properly, as sometimes the Canadian accent is quite challenging. Yeah, I think, was it Anna? Or? Yeah, thank you. You asked a question about evaluation, and the question of how should we evaluate the strategy. One thing to do with while you're implementing or when you are leading a national program is to make sure that basically you do what you would call operational research. So you implement something and you evaluate how it's working, okay? And on the other hand, we do have in every eHealth project that we have M&E, or monitoring and evaluation indicators that have been set that we are monitoring along the way. So that is one quick way of, basically these are indicators that are not health outcome related, quick ones. For example, if you're rolling out an EMR, how many healthcare facilities have an operational EMR is one. The other would be how many have issues with connectivity, or which other challenges do they have, that kind of evaluation. But I would say that we would welcome, there are some existing, but we also welcome any researchers that would take their time, look at their data from a research perspective, and take it to another level of research. So I'm not proud of how much research you've done, surely. It's not that much, but it's something that we know is quite necessary, right? Have I answered your question?
I had a second kind of question within that question, and it was if you could share with us what you have found so far that works.
Oh, okay.
With eHealth, and what has not worked.
Okay. That's it's difficult to answer in a broader way because there are different systems that we have implemented. So some have got their shortcomings and as opposed to others. But I think generally what has worked, what seems to work, is that try to pick the low-hanging fruit, try to get the easy results as quick as you can, because of the skepticism in technology. When you take so long in a project, you plan a lot and you talk about it a lot, and you don't show any results. There is a chance you're going to lose followers. Let me put it that way, or to lose support, and you might completely lose the project. So it is very important to pick on the low-hanging fruits and get them, because it creates. You basically are changing from you bring a system Of course, you involve users in planning the system, and they like it to a certain extent. But until you put it in place, you obviously will start having challenges and people that are resistant to using it. So if you do not show quick results, you are likely to face a very, very big challenge. So once you show quick results, you actually transfer the need from yourself to themselves. You create the need by making them want more. By having little, they start wanting more and more and more. So I think for me, that's one thing that I've learned as a good lesson. Obviously, the flip side of that is don't try to achieve so many things. That's something that you shouldn't do. On the other hand, again, the things that we shouldn't do is to try to implement very complex technologies. It's important to have simple technologies that work. Once again, that creates the need for more. Then you can get more complex ones depending on the need. So basically, to create the need from the users to be the ones that are burning for more is something that I guess is one would take advantage of. So that's it. The other question, once again, the names is Johansson or something.
Basically.
No, I know the comments.
Yeah.
So the question is, I just wanted to pronounce your name very well.
Johansson, Helen.
Helen. Okay, thank you. Actually, it wasn't a question, in my opinion. It was more of a comment that we build these systems early enough, in a proper way, and set standards early enough, so that in the end you can reap from that. So I will elaborate a little bit on the enterprise architecture project that I talked about, where it is basically setting standards both for technology, for interoperability of systems, to say that if an electronic medical record is to be implemented in the healthcare system, these are the technology standards it must fulfill. For the IT people that are in this room, it means these are the kind of messages that you can send, and these are the kind of messages that you can receive back from another system. So those are the interoperability technology standards that are part of that enterprise architecture. But at the same time, you set standards for how do you write the date of birth, for example, those kind of simple things, to terminology standards like how do you define mortality and morbidity, or how do you call a certain medication, or how do you identify someone. An individual has to be uniquely identified for them to have data that is continuous. Like you mentioned about, like in the long run, you get this data that's useful to follow trends of diseases. So for you to follow that, you have to have that person identified uniquely all the way for individual follow-up. But also for specific diseases, you can aggregate the data and see how each disease, the trend of each disease is going on. So the enterprise architecture work encompasses, like I said, it sounds easy, but encompasses a lot of things. We have a ministerial instruction on terminology standards, so we have already defined that. We have defined the interoperability standards as well. We don't have the interoperability technology yet in place, but that's something that we shall have in the near future. But we have defined that at least. We have the standards written. We have defined all the requirements for all the unique identifiers for individuals, for providers, for healthcare, and for drugs as well. So those are kind of the foundation for the future implementation of systems. And of course, after that, we shall reap from all the different data that you get out of that. So your comment is quite valid. I'm so glad to hear that from you. The other question was cell phone availability and how we encourage or plan to have the individuals use the cell phones to improve their own health. The strategy which we have so far, although I mentioned about the cell phone penetration, which is moving very, very fast, the resources which we have we have to make sure that we are implementing them in a very, very useful way. Now, in Rwanda specifically, for cell phones, we are targeting having these cell phones in the hands of the system, the healthcare system itself, which means at a community level, the community health workers must have these cell phones so that they can help the community surrounding them in the kind of activities that they do. We have not yet developed systems that the individual patient would say, let me check, how to manage diabetes, for example, or let me have a technology to monitor my blood pressure or something. So it is quite important that we reach that level, and I hope in the next few years we should be targeting that area. But the resources that we have so far, we are still concentrating on strengthening the healthcare system in itself, whereby at a community level, instead of, because we can't buy cell phones for all the citizens, we at least bought cell phones for all community health workers who can reach, we have 4 community health workers per village, which is about 50 to 100 households, so that we target that group that can serve the population. I hope I've answered. Yep.
Not entirely, because you said yourself.
Mm-hmm.
You said yourself that a very large number of people now have cell phones, and it's true. I mean, I've seen that with my own eyes, and I'm sure everybody who's been in the region has. So it's not a question of the health system buying cell phones, for people. It's more a question of putting up information on dietary practices, on how to avoid hypertension, things like that. That's more what I was thinking about.
Yeah, so my answer is in the prioritization. The system that, this is for Rwanda specifically, by the way. Someone else would want to implement something else. Like I said, whatever you implement has been the context of what you have, and obviously the resources that you have. So within the eHealth strategy that we have to, obviously, we review this every other time. Actually, I forgot to mention that the current version of the eHealth strategy was adopted in 2009 in April, but we just reviewed it in August this year to see if there are other new areas we should be including now. So I'm thinking that maybe if we review this in 2 years' time, that would be something to include, obviously. So given the resources that we have today, we've concentrated on developing systems that are targeting the community health workers and the providers of care. But now targeting the entire population would be the next level. But the good thing about targeting the entire population, actually, it doesn't even have to be the Minister of Health to do that. If someone came up with an application and made sure that he puts the right data that is peer-reviewed or actually acceptable by medical standards, it could even be a business for people to use. So I'm hoping that someone could catch that up and even take advantage. But specifically for Rwanda, to just answer your question, that's a very good approach, but it's about prioritization of resources that we have, which are quite limited. Yeah. I think that's all that we had. Maybe there are other questions, please.
Have you got time for another question?
Yes.
Sure.
I'm Robert Sauter. I'm from the Canadian International Development Agency. My question involves innovation. You have listed a very impressive set of initiatives, and I know they weren't created from thin air. And I'm curious to know the origins of these ideas, and what were the ingredients or the predisposing factors that helped you move towards some of these innovations? Was it the fact that donors, I assume perhaps wrongly, were providing support for certain kinds of initiatives, or were there incentives, or were there imitations of innovations that had occurred elsewhere? I'm familiar with one, for example, in Haiti, using cell phones for banking purposes related to the earthquake, where it was noticed that everybody in front of the one banking machine that was still working had a cell phone, and they said, why don't we do more banking on cell phones? And it was just an idea that someone had, and then USAID put $10 million behind an incubation project to further develop the idea. So I'm not sure if that's happened in Rwanda, but I'd be curious about the processes that you went through to arrive to where you're at today.
other questions?
Thank you. I didn't agree with you. I just wondered, is acquired immune deficiency syndrome, AIDS, a problem in Rwanda? And if you could give statistics about that?
Wanted to follow up on the question about innovation. And first, it's very impressive that you're able to mobilize your, Lungi Okoko from IDRC with the Governance for Equity in Health Systems program, Lungi. So very impressive that you're able to mobilize your stakeholders on a weekly basis for technical working group meetings. I think that speaks to your leadership. To follow up on a question about innovation, I was wondering when you have these technical working group meetings, you have the donors, the NGOs, the government there. Everyone is proposing perhaps ideas, novel ideas. And maybe some are willing to put up resources, financial, human, technical, to support these ideas. So what kind of, mechanism or process you go through in terms of deciding, prioritizing which one to support or not to support, and whether there's a systematic process for reviewing these ideas and making a decision? Thank you.
The last question.
Hi, I'm David Lewis. I'm with the eHealth Infrastructure Program at First Nations Inuit Health Branch, Health Canada. Hello. Thanks for your talk. I think there's a lot that I've gained from it that are lessons for us. Two other key elements for a national strategy, which I was hoping you could speak to, might be one, with the use of, say, electronic health records and medical records, that information is being transferred from various institutions, health service providers, and possibly health service jurisdictions. I'm wondering where privacy comes in. If you're addressing privacy issues along those lines in your strategy. The second one is, listening very carefully to the way you're leveraging cellular technology and bandwidth and the internet. Wondering, about other e-health technologies, telehealth, telemedicine applications that can be used in primary health care or health promotion or health prevention. Those place a lot of demand on additional bandwidth and connectivity, which is infrastructure that costs. Is your strategy looking at that as well?
Thank you. I'll combine Robert's and Lungi's questions because they are related. They are about innovation. And Robert's question was about innovation and how did all this come up? How come you have this strategy? And I think to summarize your question is what's the driving force behind all these things? First, I want to say that it's not only the health sector which is implementing technologies. It's the government of Rwanda has a number of pillars that have been identified for development as part of the Vision 2020. And one of those pillars is technology. So this cuts across all sectors. And this is, I think, one of the visions from His Excellency the President, who is very, very, very supportive, and he acknowledges that technology is a very, very key driving force to development of any nature, be it healthcare or agriculture or any other sector. So starting from there, every sector has tried to leverage on existing technologies. We haven't innovated a lot in terms of the technology itself, but we have been innovative in terms of implementing the existing technologies. So more of coordination and leadership and using what is available. So like I talked about having, what I would call free experts because we have all these different people that are hired by development partners and NGOs and are paid to be working there. So when we have them in the technical working group, they do play a very strong advisory role in selecting which technologies to use in different areas, and we take advantage of that. So the driving force, I would say, from a high level, national level, there's been a very high driving force, but that has trickled down into all strategies now. So healthcare strategies, agriculture strategy, education, and so on and so forth. So in other words, the eHealth strategy is kind of a mirror image of the healthcare strategy, okay? But we just try to see how technology can support that strategy moving forward as one of the key priorities. Yeah, but much as it's a vision of the high-level government, this has come down to the lowest level of administration or government or governance that you can think of. I think this is something where you feel it when you're in Rwanda, that when you talk about technology, everybody pays very strong attention. So I would say that that message has really trickled down so well. And in relation to that question, talking about how do we decide, because people have different interests that could be there to their organization or to individual interests. Of course, that happens. So when we are in the same group, actually our meeting is typically between 15 and 20 people. Now, the minimum we have is 10 people, depending on the subject of discussion. And this is chaired by myself, but it's co-chaired by one of our key partners. In fact, the technical working group is not only in eHealth, by the way. We have technical working groups in human resources for health, HIV, name it, healthcare financing, and so on and so forth. And every technical working group is chaired by someone from the ministry and co-chaired by one of the implementing partners. For example, in eHealth, it's co-chaired by someone from CDC. So we have quite a mix, and it's so difficult for someone to really advance personal interests or organizational interests in the middle of 20 people. You have to justify why you are proposing this or that. So we don't come to a situation whereby we have to vote and say, we are going for this, so that you have people who are lobbying for this or that. When you have a team of experts who are sitting together, I haven't encountered people who try to advance their interests. Of course, there has been proposals. I'll give you an example. We are implementing a system on logistics management and supply, which is an end-to-end system dealing with procurement, warehouse management, and supply to the healthcare facilities. Okay, and what we are driving at is to have a healthcare facility be able to forecast their need for medications, and also to be able to do orders and track their deliveries. Just like logistics. If you ordered for something and you had FedEx delivering it, and you're following up how far it is, right? So, just in a nutshell, we want to implement that. And then one of the implementing partners comes in the middle of all that, and he wants to propose a mobile phone-based application that is to track medications and consumables for community health workers specifically, right? It sounds like a very good innovation, actually, using some of the technologies that we had, but you're like, sorry, we can't do this. It might just you have the money to do this, it's just not possible. So maybe you could use your money to do something else. So that kind of dialogue is always happening. But the fact that we have the decision where I'm the one who makes, not me, but the ministry makes the decision, somehow you do not have those interests, personal interests or organizational interests served that way. So it's a professional group, so somehow that doesn't happen. So quickly, I think I'm running out of time. The gentleman, sorry, I didn't. Your name? Andrew, yeah. You asked about HIV. Of course, yes, we do have HIV and AIDS in Rwanda, but we have one of the lowest rates. I have to check once again, but it's around the prevalence is around 3-point-something%, which at 3.4, but I can't check the right figure. Again, it is one of the lowest in sub-Saharan Africa. So there has been very strong improvement. I would have gotten those data if I was ready for HIV specifically. But it's also available on the Ministry of Health website. You can check it up and see the levels of HIV prevalence in Rwanda. But yes, we do have HIV, and there's a lot of programs and a lot of effort and money being put into HIV. Yeah. There has been, let us talk about one system that we have used to improve. Okay, yeah, we don't have so much time, but I would have taken you through the scenario. But just to say, let me, in a very, very small summary, we do have strategies that address HIV, both for children and for mothers, because we have PMTCT, which is prevention of mother-to-child transmission, that are ongoing, and that also we have some technology supporting that. But I'll stop at that for that point. David asked about national strategy, use of EMR, privacy, and telemedicine. I'm glad to hear this question about privacy because it always comes, and I have a cliche answer to it. The paper records that we have are not any secure than the electronic systems that we're actually developing, because at least we have some encryption and we have some way of protecting electronic data. Since we don't have so much time, I'll just have to say that I believe that electronic data is more secure than the paper records that we have. But on the other hand, we do not have that strong call from the users or from the patients themselves that their data is being put out there for anybody to see. So that is not really an issue in Africa yet, but I'm sure that will come in the near future. Thank you.
Thank you very much. I really hate to close the session, so I know there are some other questions, so I apologize. But I get the privilege of thanking people. And first of all, thank you, Dr. Gakuba. You know, you began your talk by saying that high-income countries set the benchmarks for health outcomes. But I think what we've heard today tells me that you and your colleagues are setting the benchmarks for both high-income and low-income countries. So it's very impressive. Thank you. And I think your comparatives on looking at sort of what technology can do and how the rise compared to looking at health outcomes really spurs us to do more. Lastly, I just wanted to thank some of my IDRC colleagues. You know, when some of these things take a while to set up. First of all, Chetali Sena, who has really been the driver of this and support and has been there all along. Our communications department, Isabelle Acqua, Pauline Dole, Isabelle Bourgault, Tassé, Kevin Conway. These are the people that give you these great events. The 8th floor staff for their logistics. And lastly, but not least, it's welcome. And it's great to have all of you here to come on a really dreary, cold November Thursday. So thank you very much, and thank you again, Dr. Gakuba.